Hi, I'm Audrey Cunningham. Just want to introduce our speakers in a minute. This is a talk about Commit to Care. It's a public awareness campaign with a mission to level the playing field of understanding environmental strategies to combat COVID and other airborne infectious diseases like measles and tuberculosis. And we have two speakers, and you may know both of them. One, Larry Sloan. Oops, sorry. Larry Sloan got a wide background, BS degree in chemical engineering with an MBA, a lot of leadership experience in volunteer organizations, National Association of Manufacturers Council of Manufacturing, committee member of the Science Histories Institute's local Priestley Society, and he has served as CEO of AIHA, American Industrial Hygiene Association, since October 2016. And our other speaker is Ken Martinez. He's a certified industrial hygienist and an environmental engineer with 33 years of CDC experience in areas like hazardous agent exposure characterization, control practices in manufacturing, healthcare. Some of his experience spans emergency response during the World Trade Center collapse, anthrax, SARS, multi-drug resistance TB, hurricane emergency response, and the Deepwater Horizon. Right now, he operates as a chief science officer for Integrated Bioscience and Build Environmental Consortium, created to provide support of COVID-19 pandemics and response efforts nationally. And if you'd like to begin, that would be great.
Okay, very good. Good morning, everybody. It's a pleasure to be here. I'm going to kick things off before I turn it over to Ken. And let me tee up the PowerPoints.
Good.
Okay. So I want to give an introduction to how we got to Commit to Care. When you think back to the beginning days of the pandemic back in 2020, AIHA really had not done a lot in terms of outreach to end users, to the folks that we serve. And long story short, one of our past presidents, Alan Flieger, was watching Fox News one night, and he noted that Mark Cuban, formerly of the Shark Tank show, I think he may still be on Shark Tank, was assigned to one of then President Trump's task forces on the pandemic. And Alan, who had a relationship with Mark because they both come from Pittsburgh, literally sent an email out of the blue to Mr. Cuban and said, hey, what can AIHA do? We're occupational health and safety professionals. Is there a role that we should play? And Mr. Cuban responded back to his email and said, you know what, you guys should step up and take a leadership role. You should be developing education for end users. And that's what began the whole Back to Work Safely series of guidance documents that we've created throughout the year 2020 into 2021. And now we have 27 Back to Work Safely guidance documents that talk about how businesses can safely reopen and stay open from the perspective of the employer, the employee, and somebody who is a general member of the public who might be visiting the establishment. So that's the quick and dirty as to how we got into this whole business of educating the public. As a result of the Back to Work Safely project, NIOSH got us on the radar of the CDC, and as they started to award these grants to develop educational materials aimed at the public, we got shot to the top of the list. And as a result of that, they gave us a grant of $500,000 for the 2020-2021 fiscal year. And from that grant money, we partnered with IBEC to create a series of projects and products that we're very proud of. And that is then what led us to Commit to Care. So what I'm going to do now is talk about the 4 projects that were embedded in the original grant from the CDC. And that then has led us to the development of this Commit to Care web portal. And Ken is then going to go through some of the specifics of the web portal. And if we have time, we'll do a little bit of a show and tell. So the name of the grant from the CDC is Improving Clinical and Public Health Outcomes Through National Partnerships to Prevent and Control Emerging and Reemerging Infectious Disease Threats. And what's great about this partnership is that we are continuing our relationship with the CDC and our partnership with IBEC, and we continue to build out new products over time, again, with the interests of educating the public, not just about response to COVID, but against all pandemics, whether it's monkeypox or whatever the next pandemic might be. Anything that is airborne transmitted is now fair game for the Commit to Care platform. So the first project of 4 was the ongoing revision of the AIHA's publication, Role of the Industrial Hygienist in a Pandemic. And you may recall there was a very healthy group that worked on updating this publication, and we have since translated the updated publication into Spanish, courtesy of our friends down at the Peruvian Association, APEHO. In addition to the updating of the role of the IH in a pandemic publication, we created what's called a COVID exposure assessment tool through our friends at Signature Science, which we were introduced to through IBEC and Ken Martinez relationship. This COVID exposure assessment tool, which I understand has been presented to this group in the past, walks the occupational and environmental health and safety professional through a series of questions to help assess one's risk profile in the workplace. And if we have time, we'll get into a little show and tell on that. We then developed some supplemental videos now working with IBEC to help folks understand what the role is of the OEHS professional and when you should call that professional to come into your facility to assist with mitigation of risk in the face of a pandemic. And we focused on 3 different market segments: small businesses, healthcare facilities, and long-term care facilities. We then developed additional knowledge products that addressed basic risk assessment and ventilation, and we developed a very basic, but I think powerful, web-based risk assessment tool, all embodied in these little video snippets that are translated into 8 different languages. So project 1 is really more about what's the role of the OHS professional and when do you need to call them. Project 2 focused on respiratory protection. For this, we developed a series of videos that focus on risk assessment, face coverings for those that work in lower risk environments, respirators for those that work in higher risk environments, and again, we focused on small businesses, healthcare, and long-term care facilities. Again, these products are developed, they are simulcast in English and Spanish, and there are subtitles in 8 different languages. Project 3 took the Back to Work Safely guidance documents and created, again, a series of animated video snippets and tools. And we took all 27 of the Back to Work Safely guidance documents and we segmented them into 3 different sectors. One are the service sector. So these would be things like banks, dry cleaners, and other types of service providers. The manufacturing sector, which were manufacturing and warehousing, and then just general office buildings, general office space. Again, these video snippets were all developed. They're available in multiple languages, and the videos range from anywhere from 2 to 4 minutes in duration. All designed to take the complexities of the science and make it easily and readily understandable by those that do not have a scientific background. And then Project 4 was a virtual summit that was held back in January of this year, and we had 4 different panels of experts. First was the first responder community. Then we had representatives from K through 12 and institutions of higher education. We had gig economy workers. And finally, we had disadvantaged workers that are in both the construction and the agricultural markets. And all of these recordings are living on the Back to Work Safely website, and they're available for free download. And I'll mention that all of these materials that are developed under the grant, including the role of the IH in a pandemic, are all available free of charge. There's no cost to access any of these materials. So thus far, in collaboration with IBEC, we've developed a total of 20 what we call micro-training animated videos, again, targeting small business, the education sector, and healthcare. There are a variety of worksheets and infographics that you can download from the Commit to Care website. The materials are available for those that have disability issues, whether you're colorblind, there's closed captioning, and again, there are the translations into 8 different languages. And again, the Needs Assessment Summit that was broadcast back in January is available on the website. And we have then a 4-step online interactive risk assessment tool. And then we get into the Commit to Care pledge, which we'll talk about in a few minutes. And we're reaching out to a variety of organizations, and we thank Whwb for your generous partnership in this endeavor. And we have ongoing marketing and communication campaigns for all of these materials. So under project number 1, these 2 products are really designed for the OEHS professional. Again, the role of the IH in a pandemic is designed for you, the professional, and this is not posted on the Commit to Care website. And then the integrated tool on the right, there's a snapshot of what the PDF looks like. That also is designed and really to be used by you, the OEHS professional. Again, this is not listed on the Commit to Care website, but all of the other materials that we've developed are all available on Commit to Care. So Commit to Care, CARE stands for community, awareness, responsibility, and equity. So we consider Commit to Care to be a public awareness campaign. We want to help to level the playing field and make sure that everybody understands the fundamentals of airborne transmission of any virus, including things like measles and tuberculosis, and how to mitigate the risk in the workplace. We want to basically address the myths that are surrounding the spread of airborne viruses. We want to make those complexities of the science easier for the layperson to understand through very engaging tools, again, video snippets that are eye-catching and easy to follow. And we want to encourage both businesses and organizations to pledge their commitment to care for the health and well-being of employees, their clients, and customers that might frequent their business establishment. And so we have 3 different venues, ways in which you can enter the portal. You can enter as an employer, so anybody who is running or managing a business and has the responsibility to keep their employees safe and healthy, whether you're a small business, healthcare facility, or a long-term care facility. If you're an employer, if you're an employee, so that should be employee, not employer. If you're looking to, basically join thousands of companies from around the world, what do you need to be doing to make sure that you are healthy and safe in the workplace? And or if you are a member of the public, or maybe you're a concerned citizen, maybe you're a vendor that's visiting one of these companies, you might be an entrepreneur, perhaps a part of the media. What can you do to pledge to commit to care? So this slide then introduces the concept behind the Commit to Care philosophy, and these are what are called the 4 Ds. There is the density and duration, which are basically risk factors in the workspace, and then ways to mitigate that risk would be dilution and distance. And I'm now going to turn it over to Ken, who's going to lead us through the rest of the presentation. So Ken, I'll turn it over to you and advance the slides.
Thank you, Larry. And let me say it has been an honor and a privilege to collaborate with and support AIHA on this effort. It has really been a joy. And I want to thank Workplace Health Without Borders for the opportunity to talk with you about this here today. So the Commit to Care campaign was designed to be a behavioral change method. It is free. There's no charge, but we targeted this training, if you will, at the individual level to create a more common understanding of the significant components of Commit to Care. Now, we do say quite clearly that vaccinations and human diagnostics are critically important, but the greater scientific community has supported and has stated that COVID-19 is primarily transmitted through the air. It is a respiratory disease. This was not supported for a long time by the World Health Organization nor CDC, which is unfortunate. But being an airborne, primary route of airborne transmission, there are things that we can do complementary to vaccination and human diagnostics that would help to reduce the risk of transmission in the built environment. And that's where we get down to the science. So I love to tell this story because I am a scientist. As Marianne mentioned, I spent 33 years with CDC, specifically the National Institute for Occupational Safety and Health. And I am a scientist. So the first thing out of the gate we were supposed to do is I was supposed to create content for our first video, which was focused on risk factors. I wrote a 9-page document, and at the very front of it had a nice little equation about infectious diseases. My marketing team, communications team laughed at me, called me a nerd, and said, Ken, this is too much. So together we boiled down into this simple 5 Ds, which Larry had talked about before. Larry, could you advance the slides, please? Thank you. So as Larry had mentioned, there are risk factors and there are risk mitigation factors. So if we talk about density, this has to do with the number of people that might be congregating in a room. 2, 3, 4, and of course, the more people that congregate together, the greater the risk that if you encounter them, you could be exposed to someone who is infectious. Now, bear in mind that with vaccination, there is a great number of people now who could be infected with COVID-19 and are asymptomatic. So you don't know if you're walking into that circle of people, even if they're wearing masks, that they're infectious or not. So you have to consider as a risk factor the density of people, because the more people that are closer together, the greater the probability that one or more may be infected. And then that means that concentration of viral laden particles you are walking into. The other risk factor, of course, is duration. This is an occupational environmental health concept, an industrial hygiene concept, if you will. Because if you think about being exposed to a chemical agent, so let's say in a furniture stripping tank, right? So the longer that a worker has their head over this tank, the greater, the higher the risk of them inhaling toxic chemicals that will cause them harm. The same thing is true for a viral disease that is spread through the air. The longer that you're in this density of people, the longer that you're in a room that has a concentrated viral laden particles, the higher the probability that you're going to inhale those and get above the infectious dose. So what can you do to reduce that risks? Well, we talk about risk mitigation factors. So let's talk about distance first. Distance is directly related to density. So you know that the farther you are away, you reduce your risk of that concentration of cloud, because the particles tend to want to reach homogeneity as they spread out through a room. So they become less dense if these infectious particles are there. So the farther away you are, the less your risk of the concentration being high enough to be above that infectious dose. However, having stated that, we do know that there are a number of case studies in the scientific literature that have shown super spreader events that the virus particles can, if small enough, move across a room and you still can become infected. So you want to keep that distance in mind, but it is not a protector. What is more helpful, of course, is dilution. And this is directly related to your ventilation system. So either through the introduction of outdoor air or filtering the air, you actually, again, reduce that concentration of particles that could exist in a built space, in a room, that someone in that room has released because they are infected. So again, reducing the exposure to an airborne virus is the most important thing you can do to reduce the spread, the transmission. Next slide, please, Larry. So what the Commit to Care campaign is a sequential lessons, activities that you will work your way through to educate yourself about the key concepts of the 4Ds and what you can do to reduce the risk. The first of which is relative risk. Everyone conducts a risk assessment when they walk out the door, when they go to work. We choose to wear seatbelts. Some people choose to text night, which is illegal in this country. Some people smoke. We all do this type of risk assessment. So how can we simplify this to make it easy for people to walk into an environment, into a grocery store, into a restaurant, and quickly do their own risk assessment to determine, if they really want to take that risk to be exposed, potentially exposed. So we've included a small little training video, as Larry had mentioned before. It's kind of a 4-step process that was built on a model directly out of the IHN pandemic and was published by Setsema about 4 or 5 years ago. But it's based on control banding and hazard banding, but allows people to define, how many people are in a room, are they wearing masks, and very quickly come up to a conclusion. Well, you may be in a high risk environment. A good example that I'd like to provide is we're talking about a restaurant serving, right? By design, you sit at a table. You're not going to be masks because you're going to be eating, you're going to be drinking. People are laughing and talking and just having a great time. So that server walks up to that group and does not have a mask on or a respirator, the preferred protective device. But if you were to do the risk assessment, this is a group of people densely populated together, right? You don't know who's infectious, who's not, who's vaccinated, who's not. Therefore, I would categorize that the restaurant worker as someone who's at a high risk. So they should probably be wearing a mask, or better yet, an N95 respirator. So we can walk you through that in this short video. The next one is, how do you implement workforce training? We actually have videos and printed materials that can help an employee to understand what they can do to improve their work environment, their workspace. And of course, most importantly, focus on building ventilation, where we actually go into those concepts of dilution, we go into those concepts of filtration, and we even talk about portable air cleaners and how they can be used to reduce that concentration potential concentration of viral-laden particles in a room. Then we talk about determining whether you need an occupational environmental health and safety professional. This is a great question. Why would you invite the OEHS to help you out, or then industrial hygienist, though that equivalent name? Early on in the pandemic, you'd heard about hotels, and we brought in the Mayo Clinic, or we brought in doctors from Cleveland Clinic. Well, doc know how to deal with the control at the receiver level. That is through vaccination, that is through testing, that is through contact tracing. But again, as I mentioned before, because this thing is airborne, we need to do more. And in the US, our vaccination rates are only at 67%. That's fully vaccinated. That's just 2 shots. If we go to that first booster, that drops down to 45% of the US population. So we're never going to reach that herd immunity, and these reoccurring variants are really causing problems. So again, I go back to my original question: why would you ask an industrial hygienist to help out? Industrial hygiene is based on the premise of risk assessment. We identify, we characterize, and then we control. So, and actually we have to change to anticipate the hazards that may exist in the work environment. And then you identify what that hazard may be. You go through the effort of collecting samples or determining what that exposure risk may be. And then we implement control strategies. So that paradigm is, in fact, the risk assessment paradigm. It is one and the same. So that's why we're telling you, messaging to you that you really do need to seek out an industrial hygienist or an occupational environmental health and safety profession. So the next video is about understanding how to find these professionals in your community. Now, having said what I said before, we do not shirk in the Commit to Care campaign vaccination or testing. These are videos that are included as part of this procedural learning. Next slide, please, Larry. So I talked about risk, so I won't dwell a little bit of time, but again, there are videos, and this is the interactive risk assessment web tool. We encourage you to go take a look at it. Again, it's all based on good science, the Setsema article. Next slide, please, Larry. As far as workforce training, there are videos, there are printed materials, but we focus on things like, why do masks work? And what's different from a mask than a respirator? Why do respirators work? How do I properly don and doff a mask or a respirator? And how do I store a respirator? And what ventilation means for your risk of exposure. Again, these videos are only 2 to 3 minutes long. They were not to be intended to be a very detailed learning experience. We wanted people to be able to get through this training, the sequential training, within 15 minutes. So we're encouraging people to do this. Now, having said this, we all are aware that, the public at large is believing that there's a light at the end of the tunnel, that this thing is almost over. It is not. And that in large part is because of these new variants. And we're hearing now of some pharma companies that are coming out with a new vaccine in the October timeframe that is supposed to include BA4 and BA5 as their protections, all right? But we also already have BA 4.6 that is creeping up to be the dominant strain that we're seeing. And as winter hits and people start congregating indoors again, we're going to see more exposures concerning. So that light at the end of the tunnel it's just not there. We even heard Dr. Fauci say that we're going to be living with this for a long time, and vaccination will be part of that routine that we'll have to work through. So this training was meant to be evergreen. And at the current moment, we've actually been asked by AIHA and CDC to develop content for another group of videos that will focus on portable air cleaners, that will focus on germicidal ultraviolet light and how that can be used to reduce the risk of the concentration of particles in the air, and also another video on vaccination and human diagnostics. Next slide, please, Doug. I talked about ventilation. So we actually have a checklist that an employer can use to go through and making sure they're doing the right things. And we have created a checklist for portable HEPA air filtered systems. So we're going to be building on that and support activity that we're doing for AIHA and CDC. There are printed materials that I spoke to before. These are things that an employer can hang on their workplace about proper mask fit, about respirator fit, about the 4D, so that people can be reminded how simple it can be to understand what are your risk factors and your risk mitigation factors to help you reduce your risk of becoming infected. Next slide, please. Some more printed materials that are out there, wearing masks educational poster. I talked about how to find an occupational health environmental safety professional, determining how you need one, and then the FAQs for vaccination and testing policy. Next slide, please. So, important news. The Commit to Care campaign was all about training when we first started. But remember what I said at the very beginning. We wanted to be this to target the individual, to make them more aware, to help them to do their own risk assessment. So the Commit to Care site is currently evolving. We're going to change the website to be more of an advocacy campaign, and the lessons learned, the sequential learning will be one action that the person who registers can take. So we will be promoting risk assessment, which I spoke to in great detail, ventilation, and also we will be enhancing our communications on behavioral awareness. We want to give people, the individual, the information they need to make the right decisions. We need to make the content digestible. It needs to be up to date. So we will keep updating the storylines as they come. We will actually take content from AIHA. We will take content from IBEC, from our summits that we do, from our lessons learned series, and populate those into blogs for a more detailed discussion about learnings that they can do. And then lastly, as I mentioned before, the sequential learning series is only one action that you can take. So we're really, really excited about this change moving forward, and make it, and hopefully it will be more a educational tool for people beyond just the sequential training. Larry, next slide, please. And we're grateful to our current partners, and these are important, significant partners: the National Safety Council, the International Society of Indoor Air Quality and Climate, the American Biological Safety Association, the Labor's International Union of North America, and of course, Workplace Health Without Borders. We want to thank them all, and we're still inviting people to come in and join this partnership and help us to promote a cleaner environment, a safer environment. Back to you, Larry.
All right, thank you very much, Ken. Let me go ahead, and I can show a video snippet. I think we've got a little bit of time, so let me go ahead and exit out of this. This is one of the examples.
If you are responsible for creating an employee protection plan to prevent getting COVID-19, the first step is to determine if the employee is high or low risk. Some employees are interacting with people more at work, making them more vulnerable to getting sick. Reducing exposure to an airborne virus is the most important thing you can do in reducing its spread. Consider the 4 Ds to determine the risk category: duration, density, dilution, distance. Duration: how long will the employee or others be indoors? The longer time spent indoors, the more the air becomes filled with invisible airborne particles. Viruses that transmit as airborne particles, such as the viruses that cause COVID-19 and measles, pose a significant risk, as they can travel long distances, up to 20 to 30 feet, and stay active in the air for at least 4 hours. The risk of transmission while indoors is much higher than in outdoor spaces. Without the aid of sunlight to stop the virus or wind to dilute it, the small particles of the virus can remain active for hours. Even with the best HVAC systems, it is impossible to recreate the outdoor experience in an indoor space, allowing the virus to build up over time. Density: how many people are in the space? How many are not vaccinated? How many people are sick and not showing signs? And how many are not wearing masks? As these numbers increase, so does the risk. Scientific research proves masks help protect the wearer and those around them from infection and viral spread. The more unmasked, unvaccinated, or infected people without showing signs, the more likely the disease will spread. Vaccination does not provide immunity from infection, but it does decrease the risk of getting infected and makes it less severe when you do. That's why the vaccination status of the employee and the density of vaccinated individuals are important risk factors to consider. Dilution. Being outdoors is relatively safe compared to being indoors, thanks to how easy it is to dilute the virus due to more open space, moving air, and the aid of sunlight to stop the virus. One way to reduce the amount of virus in an enclosed space is by diluting the air. Just add outdoor, filtered air, or filtered recirculated air into the enclosed space using a good HVAC system. The lack of an HVAC system in older buildings or aging systems results in greater risk to those in the building. However, just opening windows to allow the outdoor air to flow in can help with dilution in these cases. Distance. How far or near are people around one another? People with COVID-19 exhale a high amount of viral particles, which is why being close to an infected person increases the risk of infection for you. The relative distance between people is a risk factor to consider. The further you are away from the infected person, the lower your risk of getting infected. Remembering the 4 Ds will help you and your employees identify their risk level and to find what steps your organization needs to take to keep them protected.
So that's an example of the types of videos that we've created under the Commit to Care platform. Animated videos, subtitled, and it's really just to simplify the science and really help to communicate the essence of what we're trying to help small businesses, healthcare facilities, long-term care facilities, and other employers do in the workplace for their workers. So that's one of several, but like I said earlier, about 20 micro videos that have been created. As Ken indicated earlier, we've got another phase of the grant we'll be working with IBEC on to create similar type videos on indoor air quality measures such as filtration and disinfection. And those will be rolling out sometime, hopefully in the middle of next year. But again, the responsibility is on us to help provide these tools to the end user to help simplify the science and to dispel the myths. Now, there is also a integrated tool, which I think you guys, you had a presentation earlier in the year on the COVID exposure assessment tool. Marianne, we can wrap things up now, or we can go through this tool. I don't know how much time we have left on our hands. So would you like to do a quick run through of the tool?
Yeah, well, what I suggest that people can ask questions if they want to see it. One of the things we can do is to direct people to the video of the presentation we heard about the tool. So people will be able to learn more about it there. And then if we get any questions about it, you can say more about it.
All right, I'll finish up the slides then here. That's basically the end of it, isn't it? Okay. Yep, that's it. Okay, why don't we open it up for questions from the audience? And again, we can delve a little bit deeper into the tool as needed.
There we go. Kevin, did you have a question?
Yeah, sorry, wasn't letting me unmute. So I just, once again, Ken and Larry, thank you so much for your energy and your devotion, your commitment to workplace health without borders. We really appreciate it. I guess the question kind of goes to the root of what we were up against at the start of the pandemic. In occupational hygiene, we knew that this virus was airborne, and we were kind of lobbying, and we wrote letters to the government. And I know the AIHA put a consensus statement around it being airborne. And I'm just wondering, are there any moves or any strategies at the moment for IBEC to kind of build bridges, with public health, maybe through the American Public Health Association? So, for example, in Canada here, we have the Chief Medical Officer of Health and we have the Medical Officers of Health. And there's still some opposition to some of these kind of, interventions. And I'm just wondering, from a bridge building perspective, is IBEC kind of working with these big organizations as well? Thank you.
I think that's a kind of a two-answer question. I'm going to defer to Larry first and let him talk as far as the Commit to Care, what additional organizations we've reached out to that I can address IBEC specifically. Larry?
Yeah, so we continue to reach out to the American Public Health Association and other allied associations in the medical community to promote the Commit to Care philosophy. And once we have the website revamped and updated, which will happen in the next couple of weeks, we're going to kind of invigorate our outreach campaign. I want to get everything all updated and really taking the messaging away specifically from COVID and making it more universal towards airborne transmitted viruses, because there's a lot of things that are going to happen down the road. We know it. And so we want to make sure that we try to more generalize the message. Now, I did have a conversation with Lawrence Sverchev a couple of weeks back about what more can AIHA do to interject our perspective as OEHS professionals with respect to articles that are coming out and talking about the response to the pandemics. And I know Lawrence was going to kind of be the broker between AIHA and IBEC. And so I'll turn it back over to Ken to kind of follow through from this point.
So from an IBEC,
and after Lawrence raised his hand.
Yeah, and I see that. From an IBEC perspective, we've been very intentional about our network. Again, we were created to bridge the gap between science and industry, and that is evidenced by the summits that we had delivered in partnership with the American Industrial Hygiene Association. So we actually had scientists from academia, from federal agencies, including EPA, CDC, and DHS. And across the table, we had big companies like Amazon and Hilton and Marriott, GM and Coca-Cola and IBM to tell us what their pain points are. And that was somewhat the same model we used in the Vulnerable Population Summit occurred back in January. So IBEC is actually pivoting a little bit, if you will, as far as how we're structured. And we want to become more of an advocacy organization to help give the scientific community, the academic community, the federal scientists a voice and how we can change behaviors and change awareness about these critical environmental mitigation strategies. We are actually working very, very closely with a federal agency at this point in time that is promoting a clean air campaign. And we're working to try to create an opportunity to create another campaign that we will be working on in addition to Commit to Care that focuses specifically on cleaning the air. So Kevin, yes, to answer your questions, right now, I think where IBEC is finding its value is being an advocate, being a voice for people and just trying to get that message out there. And we're starting to get that credibility and visibility to be an influencer in that realm. Lawrence?
Hi, can you hear me okay?
Yes.
Yes.
Okay, that's great. I actually wanted to comment on or ask Ken, ask you a question on a different topic. I'm sitting at home right now. I'm looking at a street in a suburban environment, and there are people walking up and down the street, quite isolated from each other, wearing masks. I noticed that in your talk, you did quite a bit. You mentioned sunlight on numerous occasions.
Mm-hmm.
And I'd like to ask you to address the difference in exposures between an outdoor and an indoor environment. And in the outdoor environment, the distinction between a crowded outdoor environment, like walking down a street in a major urban center, and the situation that I'm looking at where there's hardly anybody on the street. I think there's a lot of confusion in the public about when to wear a mask and when not to. I hope that's a legitimate question.
That is a legitimate question, Lawrence. And actually, as I mentioned before, everything that we deliver in the Commit to Care is based on science. And about a year and a half ago, the Department of Homeland Security did some research with the actual SARS-CoV-2 organism using simulated sunlight, different humidities. And what they determined was that in simulated sunlight, that the SARS-CoV-2 virus could only survive for 2 to 4 minutes. So it goes back to the video where we talk about, if you're ever outside and the wind is blowing, that's going to dilute the air so very, very quickly. Move that bolus of air, viral-laden aerosol particles, if it exists out there, out of your breathing zone. And then again, sunlight kills it very, very quickly. Now, let's do the opposite conversation on that. DHS also did some studies indoors and simulated sunlight through windows. They found out that the virus can actually survive on surfaces for up to 4 hours and in the air for as long as 20, 30 minutes. So that's where that risk assessment must come into play. If I'm at the golf course, for example, and I'm with my friends, I don't wear a mask because I know that I have a certain level of protection. Plus, I am fully vaccinated and double boosted. But I still, to this day, when I walk into the grocery store, I know how crowded it is. I will don a mask. I will do what I can to reduce that risk. Now, we can always have that debate about, well, masks aren't as protective as N95s, and I completely agree. But reducing what's in your breathing zone by even, 20 to 30% is to your benefit. And added to that, with the concept of the N95s, there really was no work that was done to determine if reducing the concentration by 95% is what we need. Because if you think about it from the occupational, environmental, health, and safety professional's position, we always determine the need for a respirator based on what we call our assigned protection factors. What that means is that we know what the concentration is outside that we might encounter from a chemical agent. We know what that exposure criteria is, and that assigned protection factor is that factor of reduction. So an N95 basically reduces it by 10 times, 95%. So, well, that's not 10 times, but anyway, so we do that calculation. Well, no, the assigned protection factor for an N95 is 10. That's what I meant to say. So it can take that concentration and reduce it down to just 10% of what's there. Now, is that appropriate for SARS-CoV-2? We don't know what the infectious dose is. It's been speculated. So my message to you, all of you, is that yes, N95s were the selection of choice, but any type thing you can do to protect the receiver more is an advantage. So it goes back to my point. If I go into a grocery store, I still don a mask.
Marianne?
Thanks.
Yes, thank you. So first, I want to thank you very much, Ken and Larry. It's always great to see you and to hear you. And thanks so much for all the work that you've done. My question is about the use of the audience for this and who is using it. And so I have a question for you, but I also want to invite our audience, especially we have people here from many different countries, including a number of African countries and a number of Asian countries as well, and some in Europe. And I think that this material would be of great value internationally as well as in North America. So I'm inviting other people who are here to speak up and to maybe comment on whether this is useful to you, or if you have any questions for our speakers, or maybe if there's something else that would be useful to you. But before we get to that, I do want to ask Ken and Larry what you know about who is using this material and what their reaction has been.
Larry?
I'll start by saying, so the organizations that were on that slide are starting to promote the information to their members. So they're putting information snippets in their newsletters. We haven't had any town halls with any of the association's members, but we're asking those organizations who step up to basically send out the message, send out a press release to their audiences indicating that they've signed on as a sponsor or as a partner to this effort. And we will provide them with press release copy. We will provide them with a little article that they can put into their newsletter. We're trying to make this as easy as possible for our partner sponsor organizations to push the word out to their audiences. And thank you for the prompt, Marianne. I mean, one of the things that I love to see is that those that are in this room that are part of the WHWB network to really promote committocare.org to their stakeholders and to give us feedback on what they think about the training materials.
Heather, did you have a question or a comment?
Hi, I'll try to be brief, which is a challenge for me, but and it's partly because I'm so angry, because this is all stuff that our government should have been doing for the last 3 years, right? So thank you to whoever's been doing it, and obviously Ken and Larry and others. Yeah, I wanted to raise the point about treatments. I'm not a scientist, I'm a political activist, I'm a public health person. but I'm retired. I'm over 80, but I'm married to a scientist who's even older than I am. And just to use a personal example, when we started, well, when the world started telling us what was going on, we had about 30 people, like family and friends, who wanted to know everything that we knew, right? And how to do what Ken and Larry are saying that we should all be doing, right? And now it's dwindled to about 4 people. That's it. So just that ratio, there's one, it's not statistically significant, but it does show what's happened to the public awareness, like tired, I don't care if you call it COVID tiredness or what you might call it. So I just want to say about treatments, it's very important that every time we speak to anybody, and I saw there were 77 people here, that when one says vaccinations, one should also say treatments. And that's for you, Ken, okay? Because, you know, with the variants and with the unknown, you know, nasty, wild virus we're dealing with, we have no idea what's really going to happen in the future. And as you pointed out, Ken and Larry, that it's not just COVID, it's going to be all sorts of other things too that we're going to have to deal with. So that's all. It's really a comment. And I really appreciate you asking me to speak because nobody else wants to listen to me. Okay. So.
Thank you, Heather.
If I could just make a quick comment, Heather, you know, you make a very valid point. I know so many people in my circle who have gotten the vaccinations, they've gotten the boosters, they're wearing the mask, and yet they've gotten COVID 2 and 3 times.
Yeah, exactly.
And then there are other people who have not gotten all their boosters, who have put themselves in situations where they've been close to people who've had COVID, and they have not gotten COVID.
Right.
So there's no rhyme or reason to one's DNA, one's genealogy, one's genetic makeup. It's going to perhaps cause somebody to have a little more of a proclivity for contracting the virus multiple times versus not. So we all have to be on guard, but there's this ennui, there's this exhaustion factor. I have to say, AIHCE hosted in Nashville back in May, we had 10,000 N95 masks available. You know how many people wore the masks at the conference? Like maybe 10.
Okay.
I was shocked when someone told me that.
I was very surprised myself, you know, and it was, you know, and people then reported they got COVID after the fact. And, you know, a small number based on those that attended, but still, it's like we are OEHS professionals.
Exactly.
So let me add to that.
The frustration for me, it's an issue of equity. And I do want to honor my daughter, who I have to say, I introduced, well, Alec Falker introduced me to WHWB, and we introduced all of our children. And my daughter, Jillian, had already been to the website, signed up, done all the education, because her area of expertise is around equity. And, you know, when you look at the people on this webinar or Zoom call, it tells you that, you know, where are the North American people that were on this call, these calls last year? Have they given up too, right? So there's a big education job, and I think it's mainly here in North America or Europe, Western world, sorry. I guess I'm an equity person too. I'll shut up now.
No, and that's why we were very intentional, including equity as one of the words in the Commit to Care. So with regard to what you mentioned about treatments, absolutely, Heather. And in my own circle, when people talk to me, because I know I'm knowledgeable in the area as far as not just the environmental strategies, but the variants and things that we've done. And I had one friend come to me and she asked, should I get Paxlovid? Because she was hit hard. And I said, absolutely, you should, because of her health conditions, her previous medical conditions. She is one of those people at risk. And we need to consider that. Now, bear in mind that the strategies behind Commit to Care, it's not an all or nothing kind of thing. And that's the way we created it. We wanted people to think about the different variables, if you will, that they can add to mix. If you're not vaccinated, then someone who's not vaccinated should be really enforcing, you know, the protections that they can be as a receiver, as a source, or the pathways, ventilation, wearing of respirators, those kind of things. If you are vaccinated and double boosted, I myself would consider, you know, weighting those variables a little bit differently. So it was not meant to be an all or nothing strategy, but give people the tools they need to conduct an appropriate risk assessment.
Okay, I'll just say one more thing, even though I said I'd be quiet. There's also this whole issue of age. So that's where my rage started. Of course, it started with against the government, but then it was why are we, the people over whatever the age they're using, 60 or 70, have to be more careful. But you know what? The rest of the world isn't paying attention to that. And that's part of our cultural, disregard for aging, I think.
Agreed.
Yeah. Okay.
Agreed.
So we probably all agree on this call. This is the problem. Where are the other people? Right.
So I want to address the elephant in the room that's been on the chat line, and that has to do with, are we engaging with public health? We are. Now, bear in mind, I worked for CDC for 33 years as the environmental side of things. And in my one branch, we actually had a component of medical officers, doctors, epidemiologists. We had industrial hygienists, and we would do investigations together. But there was always this pushback. So my experience, and this is my opinion, public health was always focused on what we can do to manage the disease, the symptoms, how we can protect people through vaccination, provision of antibiotics. It's never really focused on how can we reduce that risk of transmission, except perhaps in a hospital environment, because we don't want to see nosocomial infection. So I have butted heads with many doctors at CDC from the very beginning when I believed when I was an emergency responder to SARS in Toronto that was the airborne route. We actually published a paper that talked about intubation, but my medical officer from CDC said I could provide a hypothesis for infections that were occurring in the SARS North York General Hospital that was not evidenced or supported by the epidemiology. But my medical officer said, no, Ken, we can't go there. That's not the primary route. That's not what we're here to do. So that was one of the reasons that I was so much of a proponent when COVID-19 hit, because I'd already been through this and I've been preaching it from that very first timeline. Again, my colleagues at NIOSH, when H1N1 raised its ugly head, we argued the point that there was an abundance of scientific literature that showed that influenza can be transmitted through the airborne route, but it was never a priority for the medical community at CDC, public health. So we approach things very, very differently with public health and the environmental side of things. I've always hoped that we could bridge that gap and come together a little bit more. Maybe COVID-19 will be the result of that. I don't know. But that's our hope with the Commit to Care campaign. As I said before, we're not ignoring the critical components of vaccination, human diagnostic treatment, or as Heather mentioned, treatments themselves. But we want to ensure that there are other layers that can be applied to decrease that risk of transmission. That's what we're all about, having a very comprehensive, holistic approach to control.
One of the, real quickly, one of the projects that's kind of on the middle burner is to work with the CDC and create an ebook. This is down the road of all of the, again, the conventional back to work safely guidance, and rebrand it as basically a healthier workplaces under our tagline of the association, and really create more of an evergreen resource for small businesses, quite frankly, across a variety of industry sectors, to help sustain and to communicate the message about how to treat workers and the indoor built space throughout any pandemic. And Bernie raised the question about things like measles and TB and others, but we want to broaden the message and generalize it and make sure that the information that we've been working on in collaboration with IBEC remains current and updated as we move through time. So that's a future project that we hope to work on with the CDC under this grant program.
Your
I
hand
see
up
a
again,
comment.
Elsa.
Well, I just
Sorry.
wanted to answer from Saida. How can we access the 4D video? Very simply, go to the Commit to Care website and the training, it's right there. You'll have to go through the training. You just register. Again, there is no cost for doing this. And then you will have that access to the video. You'll have access to all the videos, quite honestly. Marianne, back to you.
Oh, I was just pointing out that Kevin has his hands up again. I don't see any other hands. So Kevin.
Sorry, I just see this a really great opportunity to raise this. You know, we've got a lot of people from all around the world here. I have a son who's just gone back to school. And unfortunately, you know, the public health aren't asking the kids going back to school to now wear face coverings. But anyway, my comment has to do with, you know, we're out in the public, we see people in the community where there's higher transmission wearing baggy blues, you know, where they call them baggy blues, surgical blue masks that are probably not
Right.
fitting on their face properly, or other face coverings. And as occupational hygienists, we know they're not going to be effective. But there are, you know, you can actually order respirators online now. And, you know, the breathing resistance, it's not that different. And the level of comfort's getting better now. So how do we promote the community where they're forced to go out and work, convert from surgical masks, other kinds of masks, to respirators? So, you know, in Canada, these ones here, KN99s, are easily available over the internet. And there's even children's kind of respirators. You know, how do we kind of promote their use more widely? Because we know that it's going to really help in a big way. I just wanted to put that out there.
Well, I can only speak from a U.S. perspective, and I think it has to do more with culture. If you look at the Asian countries, they've been wearers of masks and respirators for quite some time. It's common, but in the U.S., it became a polarizing argument that people said, "Oh, hell no, I won't go. I'm not going to wear a mask. I'm not going to wear it. You can't mandate to me." I don't know. To me, it's about accessibility. Before it was hard to get a hold of those, accessibility and price, of course. So, you know, people were willing to go on Amazon and buy these inexpensive masks. And so if those respirators are just as easily accessible and affordable, I think people will rethink, especially, you know, we kind of avoided making a statement that is it acceptable to live with COVID? We're still seeing, you know, tens of thousands of deaths in this country, in the US, because of our inability to get appropriately vaccinated. And how does that become acceptable? We accepted influenza because we normally see millions and millions of cases every year, and probably about 10 to 15,000 deaths due to people with pre-existing medical conditions. Are we willing to accept a higher number now for COVID? That, you know, it's okay to have 90,000 deaths? I think that COVID is still like the #3 killer in the US.
Before we go on to someone else, I just want to mention that there were a few people who posted in the chat that maybe want to say something verbally. For example, without putting someone on the spot, Harold Gaze, you mentioned that this could be useful to people in Africa. I wonder if you would like to verbally comment on how it might be useful, if that's not putting you too much on the spot. I think while we're waiting for Harold, you can go to the next hand, Audrey.
Lawrence, you're raising your hand?
Well, before you do that, Marianne, let me answer your question with regard to Africa. We actually did make a presentation to the Industrial Hygiene Association of South Africa. So we communicated to them on Commit to Care. We're hopeful that to re-engage with them again and see if we can bring them on as a partner. They have, as of yet, not committed, but they were very, very interested and eager to hear what we had to say.
I think it's back to Lawrence.
Okay. Can you explain of the number of people that are infected and dying in the United States?
We can't hear you very well. Sorry, you're breaking up there.
Okay, can you hear me now?
Yeah, much
Yes.
better.
Much better? Okay, I just have to speak up. Ken, you raised the topic, the point that as the number of deaths and number of infections within the United States is still huge. If you look at any graph from the World Health Organization, it would tell us that the pandemic is not over. Yet we constantly hear about, well, how do we prepare for the next pandemic, which is kind of a strange question when we're in the middle of that. So I'd like to take that point and ask you, why are this curve pandemic, seasonal influenza internationally had a horrible death rate, particularly among the elderly. Has this pandemic become the new seasonal influenza? And any idea from the data how there might be future combinations of that seasonal influenza and this SARS-CoV-2?
So in answer to your question, Lawrence, unfortunately, the messaging that my own interpretation from the communications coming from the United States leads on this thing are yes, that's the way they're doing this thing. We'll have to have vaccines on a regular basis. We'll have to continue to be diligent in doing our risk assessments. And it's that acceptance that they're trying to work through. In my opinion, it's because they know they can't make the change because the US is so polarized on this issue. I hope that's not the case because, unlike one thing that we did not discuss today was that one of the articles that I had read about a month ago stated that BA.5 had a R0, a replication factor of 22, one infected individual affect 22 other people. When COVID first came out, the R0 was assumed to be somewhere between 2 and 4. So these variants have gotten more and more transmissible by leap forward. And, I've seen this waffling of, well, the severity is not as bad. Well, the severity may not be as bad with those who are vaccinated, but we still have those unvaccinated. And in the US, that is 32% of our population and are going to get hit hard. And those folks are going to generate new variants because of how sick they get. And we're going to see people who are asymptomatic, where I read one report that stated as many as 56% of a small population that they actually did investigate on were asymptomatic and of a vaccinated population. And those people who get infected will breed new variants as well that have the ability to evade our antibody response. And that is problematic. I see something in the chat, Nico. Yes, it was South African Industrial Hygiene. That's who we spoke with.
Yeah, Karen Santo Pietro has something in the chat, and then I'll ask you in a minute, Dorothy. Karen says, are there resources about using CO2 monitors? There's a lot of interest in the Philippines to use CO2 monitors as a measure of fresh air coming into the space.
Okay, I can address that one. It's a kind of peeve of mine. CO2 only indicates outdoor air, period, right? And it helps you to understand what the ventilation, how good your ventilation rate is or how bad your ventilation rate, but it doesn't address the issue of, can we use filtration? Can I put a portable air cleaner in there? So the other component that you have to think about, that we all have to think about, and I as an engineer, is that as you increase more outdoor air, you're making your ventilation system work harder. Is your ventilation designed to include that much outdoor air? So there needs to be a balance. Not only that, is there are power consumptions with including more outdoor, because during the hot summer months, you're bringing in hot, humid air. Your system is required then to dehumidify that and cool that air. That requires more energy. That requires an increased cost. And maybe your system cannot keep up with that. So CO2 monitors are very, very helpful to understanding how much outdoor air you are, but it's not the only solution. So there are other products on the market right now that, for example, and this is not an endorsement, there are two that I'm aware of, one called Poppy, one called Safe Traces, that actually use a DNA encased genetic material, not DNA, genetic material encased in a water molecule or water particle, and you can aerosolize that and you can collect that. That will give you an indication of both outdoor air and filtration and how effective your ventilation system is.
Hopefully that answers your question, Karen. Dorothy, you had your hand up.
Yeah, thanks. Ken, Larry, thank you for this. I'm the person who talks about hazard assessment as opposed to risk assessment, but we'll talk about that another day. It's a different approach, perhaps, to as a hygienist. But the thing that Ken knows me for is for ranting and raving about disinfection and hygiene theater. Yeah. And I heard you say something about preparing materials about disinfection. I would like to publicly encourage you to look at the materials that have been developed by a variety of folks, some of whom are in occupational health, but others who have been focused on, particularly on schools and what it means in
Right.
schools to have toxic products that are asthmagens, in that they both cause and trigger asthma. So the most popular disinfectants around these days do that. The ones that contain quats or quaternary ammonium compounds also screw around with reproductive systems, cardiovascular systems. They're nasty enough. California's biomonitoring has them on their lists. And but the thing is that there are options. So
Yes.
if soap and water are good enough for our hands, why is it not good enough for surfaces? In many cases, microfiber cloths are useful. And the US EPA list of safer choice active ingredients is very useful. And personally, I just have been saying to people, if you have to disinfect, remembering your points about how long the virus hangs about, maybe you can just air out a space. Maybe, sunlight will do the trick, whatever. If you really do have to disinfect, a product that contains hydrogen peroxide only as the active ingredient and not something else that's going to be more nasty is the way to go. But you also then have to think about what are the protections that people need, both those who apply and those who come into the space afterwards, because there are questions about what happens when hydrogen peroxide products get into the air and the air chemistry. There's some work being done in Canada on that I know about. So anyway, I'm just encouraging you to do something that unfortunately most hygienists have ignored, which is the toxic properties of cleaning and disinfecting products.
Right. No, and Dorothy, I completely agree with you. Now, we were not intentional to ignore disinfection in our communications. We just wanted to weight our messaging on ventilation because that's where your most bang for the buck is going to be when something is airborne.
Yeah.
And everyone was promoting from a public health perspective, oh, it's all about disinfection and cleaning. Well, it wasn't. That's when they believed that the primary route was fomite transmission. But now that it's flopped the other way, we wanted to focus on that messaging of cleaning the air, as opposed to, do you need to sit there and apply Clorox all over everything? Yeah, not really, because the probability of you contracting COVID from touching a surface that someone else has touched who is sick into your face is not that high. But there are now other diseases that we need to be concerned about. Monkeypox is on the horizon. These and influenza does benefit from a better hygiene perspective. So we are going to shift in that direction, as Larry just posted in the chat. Part of the next phase of what we're going to be focusing on is germicidal ultraviolet light as an upper air disinfection, not of surfaces, because even that tried and proven technology can be applied incorrectly and can cause harm. I mean, it's UVC, and if you're looking at it directly, if you're too close, it will have optical effects that are damaging. So it's anything that's put in the built space. This is me preaching. Anything that's put in the built space to kill a microorganism, you must consider the consequence to the individuals, the occupants, because we are nothing but a compilation of cells. So what is that doing to our cells? So I agree with you completely.
Yeah. And the other thing just that I've learned the hard way when I talk about ventilation is I've taken to talking about the 2 F's, fresh and filtered air. And that I have a good friend who is a longtime health and safety activist who said to me, as we sat in a restaurant, why would I need an air filter? And it just sort of like, if Harvey doesn't get it, I think there are a whole lot of other people out there who don't. And the idea being that what the use, where filters fit in, especially when you don't have an HVAC system. That the importance of things like the Corsi Rosenthal boxes or the commercial units, as long as they don't produce ozone. I've got a bit
So
of
along that line, Dorothy, because I see Kevin has just posted something about far UV. So we know that UVC at the 254 It comes from the sun, but it doesn't penetrate the ozone. We generate the UVC by arc welding or types of welding operations, or lights, for example, mercury vapor lights that we use to produce UV for disinfection purposes. Far UV, on the other hand, at least what I've read, has the potential to produce ozone, whereas the UV in the 254 does not, or at the concentrations of ozone are very, 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 very small. So along what you were talking about, Dorothy, if we start promoting far UV, has anyone really done the research and determined how much ozone is it producing? And does that cascade some other health impacts that we need to be aware of and consider?
And just on the UV stuff, I think what's practical in terms of most like small workplaces, the places without, regular custodial help, those kinds of things, what do people need to practically, what can they be doing, and where does UV really fit in every kind of situation?
Right. And UV is radiation. And with radiation, we know its concentration, its time of exposure, and its distance from that source. And this is why I've never been a strong proponent of putting in a ventilation system unless that company has done its work, because the air is moving pretty doggone fast. So are we getting the resident time near that source to get an effective kill of microorganisms? Why does upper air UV work so well? CDC is clear to make the recommendation that we have to have good mixing, because what we want to do is we're only irradiating the upper areas of the room, first foot. And so air must be actually moved and eventually make its way up into those upper levels. And CDC actually predicts for tuberculosis how long it would take to clear a room, either using a portable air cleaner or an ultraviolet light device. But I did a lot of work back when I was with NIOSH of assessing clinics, laboratories that used UV and some of these upper air UV systems. And you could take this detector and see that the concentrations were, above criteria levels for an 8-hour exposure. And you have a healthcare worker in there, we let them know that the lures were wrong. So yes, Dorothy, answered your question. There are decisions to be made as far as where is it applicable and where it is not. My personal preference is, in the absence of upgrading your ventilation system, use a portable air cleaner with a HEPA filter, and avoid those ones that claim that they have other technologies to clean the air that are not proven, right? We could talk about ozone generators. We can talk about both bipolar ionization. We can talk about the use of titanium dioxide. As long as they don't put anything into the air, I don't have a problem with their application. But is it really that they're effective in kill, or at least show us the science?
Thank you so much. It's probably about time to wrap up. This will be posted eventually on our website or fairly soon. Maybe is there one more question or comment before we thank the authors and close? Anything else? It's been awesome. Ken and Larry, thank you so much. I'm excited to I looked at the website, but to look a little bit more. Kevin.
Yeah, I can't help myself. It's but there's an emergency doctor here in Canada that he's a co-founder of Masks for Canada, and he's set up an app. It's called Raven. It's a Raven app. So you can go into a cafe or a restaurant. You can take a carbon dioxide measurement. You can actually post that on the app, and it's a global view of, and it shows where all hotspots are of carbon dioxide.
Okay.
As far as we're raising awareness of where indoor air quality is poor, it's probably a good app to look at, and it's very useful, has a good useful purpose for advocacy. I just wanted to make a mention of that.
Thank you, Kevin. And actually, that's a good opportunity for Larry and I to promote the COVID exposure assessment tool. Take it, use it, because it does this double tracking. You can set up different scenarios. It will allow you to understand, what if I just wear a mask? What if I wear just a bandana? What if I wear an N95? And it will actually give the user that indication of how much of an improvement there is. And to Karen's point before, it does include CO2 measurements in there as well. If I promote more outdoor air coming in, fresh air, and I get the CO2 levels down to 450, how does that reduce my risk of transmission? And it gives you a nice little visual at the end of your 2 different pathways that you choose on what the risk factor is. So is it red? Is it yellow? Is it green? And it also includes the positivity in your community, the vaccination rate in your community, the variants that currently exist. It's a very comprehensive product, and it's all the equations. If we'll share with you the paper if interested. It's due to come out in September of 2020 in Science Advances, and all of the modeling, which I don't even understand as an engineer, is all in JavaScript. But it's a powerful tool. Oh, and what lastly, they did compare the seat with 11 super spreader events, and the R squared, the correlation factor, was 0.94, which is incredible.
All right. Excellent. And thanks to all the people that joined us. I really appreciate that. Ken and Larry, I'm sure we'll hear more from you. Just thank you, everyone.
Thank you all. Larry?
Thank you
Yeah.
very much. Appreciate it.
Thanks very much. It's really good. And I see from the chat, we have a lot of people who are interested and will be checking out the Commit to Care website. So I know you need to leave, and we really appreciate your sharing your time so generously.